treatment. In order to do that, you know, informed consent is really important, and that's where ClinCheck is so useful. If ever, you can hear my stomach rumbling, sorry. If ever I have a limited goal treatment and I'm only moving, say, something anteriorly or something for restorative and not doing a comprehensive, I will show the patient the ClinCheck, because I want them and the dentist, if I'm not the treating dentist, to be sure that's not my treatment goal. And I want to clear that with everyone first beforehand. But that's a reason for a buccal open bite at the end, because maybe it wasn't part of our treatment objective. Again, usually it is, but in this case, perhaps in some cases that you see may not be. This patient here is a transfer case, and he's the cousin of one of my friends. He came actually from France last year, and he had started Invisalign over there, and you'll see in a minute he had a very big anterior open bite. And this is now how he presented to me. And this is, you know, as I said right at the beginning, I have to do all the hard work now, usually finishing, and all the issues have been caused already. Now I have to go and undo them. He's going to need a lot of buccal root torque. You know, it's now this has been done, the tip. Now I have to create the moment instead of being aware of that from the beginning and controlling that expansion with buccal root torque and a good attachment. But I will see what the first ClinCheck was and what the dentist did. Now I have this posterior open bite, so I need a combination: buccal root torque on the upper, proper leveling on the lower. Although I have to be careful here because he started with the anterior open bite, so I don't want to level as much as what I would do with a patient who started with a deep bite, which is often when we see this incisor interference. So I need extrusion, buccal root torque in order to solve this. So this was his original malocclusion. And you can see that I don't know if they were going to use anterior elastics, but there's a lot of attachments here pretty much on every tooth. I don't like to do that if I can help it. So I wanted to see what movements would build in, because I have to fix those. I have to fix this bite now. So it's really useful for me to see the initial. So what I'm doing here, a lot of buccal root torque, and you can see my trick, which I showed you with the dentist's son. That's a lot. So I'm going to do buccal and palatal attachments now. I don't have G8 for this anymore because this was already treated before G8 came along, unfortunately, and may not have happened with G8. In this case, because he started with an anterior open bite, it's okay to see heavy anterior attachments. I don't want to open him up too much because I don't want that tongue to get in there anymore. So it's a combination of absolute extrusion, nice leveling posteriorly. He'll have his third molars out, but I still want to align them or get them out of the way so they're not interfering, and so they're not a cause of that open bite. Really overcorrect that buccal root torque, as you can see here, and very, very, you know, tight contacts, at least in the middle and of course anteriorly, because he started with anterior open bite. If he started with deep bite, he would have much less red contact anteriorly. Much easier to prevent than to treat once it's all happened. So supereruption, number 11, supereruption of teeth not included in the scan or PVS. So this is green. It's a patient-related variable, right? This would be either a younger patient with erupting teeth, or it would be maybe a patient with erupting third molars, still a younger patient. Sometimes when we take our intraoral scan, the 12-year-old molars haven't erupted yet, or they're only partially erupted. And if we have, you know, a significant malocclusion, these posterior teeth can super erupt and create this premature contact. So during treatment, our 12-year-old molars in this case may be erupting. We don't tend to notice so much when the aligners are inserted. Then when the aligners are removed and we ask the patient to occlude, we're very surprised to see anterior open occlusion. So diagnosis of this is that we look for that premature contact or that erupting tooth, posteriorly. And again, it could be a 12-year-old molar, or it might be a third molar that's erupted beyond the occlusal plane. So if we're aware of a tooth erupting and we're in the middle of our aligner treatment, what do we do? Because we don't want to stop and do a new scan if we don't have to, because everything else is working really beautifully. So a very simple technique, and many of you will be aware of this, is to place some composite resin, like a bite block, onto the erupting tooth so that it can't erupt beyond that occlusal plane. So very simply, bonding some composite onto the occlusal, and that will maintain that tooth below that level of the occlusal plane. And then when we're ready, we can, if we needed to do refinement or additional aligners, then we can include that tooth in the scan, having removed then that composite. The other alternative, if it's a patient, we know the tooth is going to erupt and it's quite low down so that we qualify for an eruption tab, is that we use the team product, and this eruption tab will prevent that super eruption of that posterior tooth. These can't always be placed though. They have to be triggered quite specifically. Obviously on our treatment form, we need to request them. But if the tooth is quite close to the occlusal surface, sometimes they can't be placed, in which case you may want to include it in the scan and partially cover it, or do something like this. So sometimes, even though we request an eruption tab, it's not possible for that software, just because of the manufacturing, for them to place it in there. So the composite is a really good clinical tip. Another patient-related factor in green here, posterior intrusion, this is our last factor now, contributed to by aligner thickness. Now, this is the one that got blamed 22 years ago when we started finishing our very initial computer program sequential aligner patients with Invisalign. And doctors would say, oh yeah, we're finishing with posterior open bite because of the thickness of the aligner. And I knew from day one that wasn't the case. Even in 1997, people were using Essex, and very good orthodontists were using Essex retainers to maintain their beautifully treated fixed appliance occlusions. Why would doctors have been doing that, using Essex retainers on their beautiful fixed cases, if putting something like this in created a posterior open bite? Didn't make sense to me. The other reason it doesn't make sense to me is because when you look at the thickness, and Invisalign, even though the material changed, it was always very similar thickness. The double thickness of an aligner does not exceed the freeway space. So you know what freeway space is when we're at rest. Hopefully you're at rest now listening to us. Your teeth are not together. There are some really good studies that show our teeth are only together 6 minutes a day, and that is when we swallow and when we chew. So unless you have a bruxer, someone who's clenching and bruxing, it's got to be duration, intensity, frequency. It's got to be most of the time, in which case they're probably going to have very severe TMD. This is not even possible if you're using Invisalign aligners with this thickness. Again, because the patient, unless they're biting, they're not going to be able to create that force. And even biting, a few times a day is not going to create that. It's got to be a sustained force to actually intrude the posterior of the occlusion. So it just never made sense to me. It's possible, yeah, if you've got a severe bruxer or a clencher habitually, but that's going to be very, very rare. And the solution to that would be the bite ramps on your aligners. For me, I put them on the canines, and you can use bite ramps on the retainers as well, on the Vivera retainer, and that's what I would do if I had a severe clencher or a grinder. If we do have intrusion in retention, Vivera for me is a really, it's actually one of the best things that Align technology does for us. We get 3 sets. It's a great material. It doesn't stain. It doesn't wear. Smart track material is made for tooth movement. Vivera material is made for tooth retention. So it's made to last, and we get 3 sets. So if I do need to do any adjunctive movement, or if I do have some movement within my retention period, then I can take one of those appliances and I can create my adjunctive movement. And then I've still got two more whole retainers, so I don't have to order more retainers. So it's really good adjunct for performing adjunctive movements, or if we did have some movement within retention, which hopefully if we've given our patients a good retention protocol, that's not going to happen. So moving along to our next station, we know there are a lot of causes. I think I went through 12, and you may be able to think of a few more, but this is for completion. We're going to look at some ClinCheck Pro strategies that will help us in avoiding, because the key is prevention. If we're aware of the causes, we're much more likely to be able to prevent these issues when we're dealing with our ClinCheck Pro software. One of the main keys to me is to finish well, because if we finish well with tight buccal occlusion on the ClinCheck Pro, then we've got a much better chance, or pretty much the only chance, of finishing well clinically. If we have a loose occlusion on ClinCheck final position, it's almost impossible for the patient to finish better clinically. Occasionally that will happen, but it's very, very rare. So our best, one of the most, I guess, logical strategies is to finish with an occlusion that we really love in our final stage of ClinCheck. So coming back to our three major variables, the patient, the clinician, and the aligner, we need to program the aligner. And how do we do that? We do that on ClinCheck. We become very systematic at looking at our ClinChecks. There's, in a way, less and less for us to do in terms of gross mechanics, because a lot of these solutions are being applied automatically by the Invisalign software, by the Treat software or the ClinCheck Pro software. For us now, it's orthodontic, it's really good finishing details. And these are the things that we should be doing. We shouldn't be doing and worrying about all of the other gross movements, because these days we have this incredibly sophisticated digitally programmed product, which is only going to get better and better. It has to, it's digital, and we're learning all the time more and more. So when we look at this systematically, and my goal is to finish very well, what tools do I have in ClinCheck? I'm programming my mechanics here. There are only 4: final position, IPR, attachments and aligner features, and staging. These are the only things that I can change when I'm programming my aligner. The other things I can do is manage my patient, and I can be educated about aligners and my staff. But in terms of programming the aligner, this is where I have my flexibility. So let's look at these. Earlier on, we were talking about G8 and the Smart Force application, and I said that's kind of invisible because it's where the aligner now is going to be manufactured and programmed to create these very clever pressure surfaces. It's not just always now going to be on the active surface of the optimized attachment. It's also now a very clever whole aligner, which is going to be selecting parts of the crown to selectively apply pressure. How do we know that? Because we can't see it on ClinCheck. If you go to your tooth movements tables, so you can access by the tables, tooth movement table, the teeth that are shaded in blue have got the Smart Force aligner activation applied. So if you're not sure, you can look at your table and see if the Smart Force activation is actually applied. So when I finish my final position, when I go to my final position of my ClinCheck checking, this is prevention, right? Don't move what we don't need to move. So if the patient comes in, and often they will, at least one side, sometimes both if we're lucky, they'll have really good AP position of buccal occlusion. With an arch wire, we ruin that very often because we use continuous arch wire mechanics. yes, we can get it back to where it was or somewhere better. But if it's already where we want it, the beauty of Invisalign is that we don't have to move it. So look for something you like. If there's a great buccal occlusion, doesn't mean you don't want to move everything, but don't move what we don't have to. We don't expand unnecessarily. We know how to check for that. Superimposition tool, or go and lock that tooth position or make it unmovable, and you can, or lock it, and you'll see where it started and where it finished. And if it's very different, bring it back to the original, unlock it, and then you can start working on the arch form from there. Minor overcorrection of extruding teeth. So remember I said I don't overcorrect a lot, only just like the tolerance of a little piece of plastic. And we have deep bite at G8 working for us there, so we won't have to overcorrect anymore for those of you who used to love to do that. Incisor torque, yes, I like to maintain my incisor torque. It's not necessarily a lot of overcorrection, but it's retracting while I maintain that torque. And finishing with a super class 1, because, you know, if we finish quarter of a unit class 2, we're not going to be able to get that beautiful tight buccal segment. In terms of IPR, that can come back to bite us if we have programmed IPR. If you have accepted IPR or asked for it on your prescription form and then accepted it on your ClinCheck, and then you don't perform it clinically and there's quite a bit of it, you're going to have crowding within your aligner, and that is going to result in some intrusion. The teeth have to go somewhere. They're being squeezed. They can't squeeze down like they would probably with fixed appliances. They're going to squeeze up or rotate or tip within the aligner. All of those things will upset our buccal occlusion. So don't ignore programmed IPR unless it's overcorrection of space closure, say an extraction space, which is what I showed you before, instead of asking for a whole C chain. I monitor all the contacts, especially if I'm expanding or rotating. All of my contacts are monitored anyway, so that if I do have something very tight, I can just take a very ultra fine strip and put, 0.08 and just make sure those teeth can slide past each other. Sometimes, when we're expanding, we know, just like every movement, every mechanical device, we don't get 100%. The ClinCheck assumes we get 100%. So if we're expanding a millimeter and we're using some of that for maybe a canine rotation, and we don't get all of our expansion, we can lack space for that rotating canine. And what's going to happen, especially to a canine or a lateral incisor, because there's not a lot of natural undercut. So make sure you check, especially around rotating teeth, or if you're gaining space through expansion, check the contacts of adjacent teeth, because the underexpression of all the movements will be cumulative, and that may contribute to crowding within the aligner and then unwanted intrusion. How about attachments and aligner features? So this is another ClinCheck step that I go through in terms of my aligner programming to make sure my mechanics are in place. We need to ensure that our attachment position and design is there for extruding teeth. Extruding teeth need a push surface. Again, most of the time we have optimized attachments programmed. Fantastic. It's any extrusion more than 0.5 mil is going to trigger an extrusion optimized attachment. Expansion. If we're expanding, now we have G8. Those attachments are going to be placed automatically. Before, I used to have to place that attachment and make sure that I simultaneously staged that buccal root torque. That's going to be taken care of now, at least on our premolars and our first molar. So you may still want to keep these strategies in place for your second molars, because at the moment G8, as far as I can tell, and the clinical team might verify that, is only premolars and first molar. The torque and power ridges. So when we're retracting, and I said we lose torque, actually for me, power ridges for me are like almost every Invisalign solution or product. They will help me but they're not always going to be the whole solution. Just like the bite rams. The bite rams will help me in a deep bite case, but it's not the whole solution. So power ridges, I like them, especially on the lower, if I'm retracting my lower incisors and usually intruding them. And that's where we often see the first signs of recession. So I love power ridges to protect my lower incisor roots. On the upper, power ridges are, you can see them, right? So, and many of my patients might be adults, and if they don't, I'm trying to make this as aesthetic as possible. So maybe I'll remove the power ridge from the upper, but I'm going to keep it on the lower. And the reason I can do that is because on many of my cases, I have palatal attachments on my incisors, which will help me maintain that aligner on that incisor. So for me, it's either a power ridge or a palatal attachment for the upper, and I love the power ridge on the lower for maintaining torque and protecting that very thin labial bone and gingiva. Deep bite resolution, we know that we need undercuts for intrusion adjacent to what we're intruding. Again, G8 is going to take care of that. G5 started to. Now we've got G8 with not just attachments, but additional attachment on the lateral incisor, and also the staging, and the floor system is all been revamped. And the addition of bite ramps for a lot of our deep bite cases will be triggered if we allow that on the prescription form. And then staging. Staging to me is something that's really very exciting because nobody knows a lot about it. You know, we're just starting, even though we've had Invisalign, and I've been using it for since 24 years, a long time. I'm always learning, and plus it's always changing. So I have to keep up with all of these new changes and make sure how my traditional strategies fit in with the new solutions. Staging for me is somewhere that's really exciting. It hasn't changed a whole lot. The company has got, yes, special staging for G6 in extraction protocols, but you know, there's a lot more that we can work on and figure out. So it's very exciting. Some of the keys in terms of staging, and you know, what does staging mean? It means when is the tooth moving? And it's not just when is it moving in the whole treatment plan, but in relation to other teeth. Again, malocclusions are three-dimensional, and often we just look at one arch when we're programming our ClinCheck. We have to think about the two arches and what we're doing when the patient actually finishes off and brings those two arches together. One of the keys that we learn about in orthodontics is overbite before overjet, right? That's one of the principles. We need to do that because if we're retracting our overjet and we still have a deep bite, we're going to end up with incisor interference, whether we're using aligners or fixed appliances or whatever, it doesn't matter. So we need to reduce overbite before we look at overjet. It's just makes sense biologically and mechanically. Otherwise, we interfere with our incisors. Simultaneous staging. So how do I do that? Simultaneous staging of 3 to 5 degrees. So this is expansion now, extra buccal root torque when expanding. So we've spoken about expansion. This is what I program maybe on my 12-year-old molars. So if G8 is going to take care of our premolars and our first molars, we can make sure that we have this on our second and or third molars as well. Simultaneous staging, palatal and lingual root torque. Here we go for overjet reduction when retracting. So I'm going to maintain, even if the patient's really protrusive, I'm going to maintain a lot of that torque. I'm not going to level off gradually or simultaneously. I'm going to maintain it and then level off towards the end anything excess. Why? Because it's much easier to do this with the crown than at the end to produce the palatal root torque. So I want a very short finishing series of aligners if I'm going to need one at all. Segmentally stage expansion. So the transverse, we can use staging patterns to help us with expanding as well. The 7 and 5. So if I have a whole segment in crossbite, I take my terminal molar and the second premolar, usually the 7 and 5, and correct that first, and then the 6 and 4. These principles are just asking, it's the same as the frogging, it's just asking the aligner to do less so that any negative effects of this physical mechanics are really dissipated through the whole aligner. It's not going to express in terms of the rest of the occlusion. The force of that, or the negative effect, will be overridden by the whole aligner product if we're only moving a few teeth at a time. Now, of course, all of this sounds great, but we also have to keep in mind we need to finish the case. So I'm not advocating having more and more aligner stages, but sometimes we can do this without making a case longer, and that's when I choose to do that. Consider, and the deep bite, consider alternate canine and incisor intrusion in deep bite. So we saw an example of that staging earlier on. If the overjet is available, so if you've got tight overjet and you want to retract, or you're closing upper extraction space, you want to clear away the lower incisors vertically and AP wise before we start retracting the uppers. I don't like 1 to 1 to 1 to 1. I like to have a bit of separation because I know clinically it's going to express a little differently to what it does on clean check. So if I'm going to do that, I need overjet available. So let's look at some examples of staging. So this is a crossbite here. If it was a whole segment, I would be programming the 7 and the 5, and then the 6 and the 4. Let's take that back again because that's interesting here. So here it's a single tooth. But even then, you know, we say single tooth crossbite is easy to correct with aligners. Well, some yes, and some, you know, you keep going, and it depends on the vertical overlap, right? The clean check's just going to merge the tooth through. Sometimes we need to intrude, cross over, and then extrude. And that's what you can see I'm doing here. And it will depend. This is a lot of vertical overbite here, overlap. So I'm not just going to try and push it through the lower arch, because even though the patient's wearing the aligners most of the time, the aligners are out and the patient's going to chew. And when the patient chews, they can push a tooth back. What is the activation of the aligner? 0.25. What is the compression of a periodontal ligament? 0.25. So every time the patient bites, they can push that crossbite back. So I like to clear space by intruding, bring across, and then extrude. And you can see that's just slightly extruded, and I've got a nice push surface on there. Finishing with very nice, tight, ideal buccal segments. Because if you don't finish well here, you're not going to finish well clinically. So next time you have an Invisalign result and you think, it could have been better, look at your clean check. And most of the time you'll see that you accepted the final position, which actually could have been better. So final position checking is really important when we're talking about now our finishing. So in summary, the strategies to tighten the occlusion: ideal dental alignment and interdigitation, green or red occlusal contacts visible, especially when we're extruding, eliminate unneeded posterior expansion. So you can use that trick where you make the tooth unmovable and check and see, or you use superimposition and get rid of unwanted expansion in your lower arch, and then you can occlude the upper and get rid of it, any upper unwanted expansion. Buccal crown torque, buccal crown torque on the lower arch. So if the lower arch is really lingually inclined, then it's very hard to have a good looking upper occlusion and still be tight. It's going to look too tipped in. So make sure your crown torque on the lower, it's not totally vertical, but just nicely lingually inclined, and then buccal root torque on the upper, and that makes a nice tight interdigitating occlusion. And those tools in the 3D are here. And then the extrusion, intrusion. So this is the nice progressive torque. Don't forget that. And that's what's going to create the final aesthetics. So not just a well interdigitating buccal occlusion, but beautiful smile aesthetics, which really is what most patients are going to want to have. I hope most of you or all of you are using the Invisalign photo uploader app, which you can access on a smartphone or on an iPad. I use mine for lots of reasons, mainly because the photos go now straight to my IDS. All my patients are registered there once I register them on the app, and it's much less work for me and for my staff as well. But the other great reason is this smile tool. So if we use the photo upload app, we get this smile view, and this is amazing for our patients, not only to appreciate their new smile, but also for me to create that smile and maybe reduce some gingiva or reduce a black triangle. So consider using that app if you're not using it already. Lots of advantages. It's not just a marketing gimmick. Lots of clinical advantages. So now we've, worked our way through this web of stations. We've looked at what gaps are possible, what are the solutions and causes, and then some of the ClinCheck strategies, the key ClinCheck steps in programming that relate to finishing with a nice buccal interdigitation. So I hope that you have a few different ideas or look at your ClinCheck maybe a few different ways. I hope that you're as excited about G8 as I am, because, I am going to test it just like you are, and we'll come back and talk about all of this maybe in 6 or 12 months' time when we start finishing a few cases with it. But I'm really happy that the company is addressing finishing, because this is just moving, Invisalign ahead into a really useful digital tool that is capable of producing fantastic outcomes, and that's our goal. So with that, thank you for your attention, and I'm going to hand over and see if we have any questions.
Thank you, Dr. Vicky. This was a very nice lecture, a lot of information, and we have quite a few questions from our attendee. The first question, Doctor asks, Dr. Warner, can we also talk about unexpressed rotation, especially of the canines, and how to prevent or correct that?
Okay. So canines, I think it's possibly what's happening is that when I talked about if you've got a rotation on a canine, you will trigger a canine rotation attachment. Actually, I call them the devil's horns, don't tell line technology, but it's like the teardrop, and the more rotation you have, the bigger that attachment. And that actually, if you're just rotating and it's a big attachment, a devil horn, it works fine for me. The issue, I think, when I'm getting incomplete canine rotation is it can be two: lack of space, or the attachment that was triggered is not sufficient to create that rotation. So for example, I showed the extraction case when the canine is retracting, and G8 would just trigger the root control attachments. Well, they will control the root, but they're not going to control the extrusion as well. Or if that was rotating, it wouldn't control the extrusion of the rotation effectively. So look at the attachment was there. Look where your canine is rotating. You need space. So make sure if there's any IPR program there or of a lot of expansion behind it, that expansion is not going to track 100%. So watch for your space. And I don't mean that you have to, where's my strip? I don't have it, go through every canine or every tooth that's moving and create visible space. No, but check with a little strip. Let me get my little strip that I have here in my clinic. So, check with this is for me on every Invisalign tray. And this is Brasseler, but there are different brands. And there is a non-cutting surface in the middle. So that's what I use instead of floss to check. So if I've got a rotating canine, I'll check mesial or distal, make sure that this can go down quite nicely. If it doesn't, then I simply do a little bit of a polish on each side with a very ultra thin, so maybe a 0.08 strip. So space. If you've got IPR program, make sure you're actually doing that unless it's an overcorrection of space closure. The next thing we need is mechanics, right? You need to create a rotation. You need a push surface. If you're just rotating a canine with only the root control attachments or a very small optimized attachment, maybe it's extruding and you've got the very small optimized, it's not enough for a rotation. And the biggest movement is going to trigger the attachment. So I'm not sure what attachments you've been dealing with, but if I have a canine rotation, the one that I will, I wonder if I hope I don't muck anything up by going back to my lectures, but the one that I will trigger is going to be, let's see if I've got a picture, because I probably have, one which has got, yeah, so that's not going to help me for a rotation. The devil's horn, it's going to be more like this. And it's going to be a diagonal attachment with a push surface that helps me rotate on the distal of the canine. The other benefit of having an attachment, sorry, like this is on a canine is that it's going to keep it in the aligner, because if the aligner is spinning, it's also going to want to intrude. Remember, teeth can't do anything but not express 100% or intrude. So this attachment has a great undercut. So I would make this on the canine. So you drag and take this off, drag and drop, and I put it a little bit on the distal and also a little bit, you know, not halfway up the crown. I try and get it as low as possible near the occlusal surface if I'm extruding a tooth or rotating, because that aligner has to grab it and it has to pull it round. So that would be my canine rotation attachment right here. And I don't even, you know, that works well for me. I don't even necessarily overcorrect my rotations on a canine. If you're really concerned, maybe 1 or 2 stages, but not a lot. It's more, is your final position correct? So make sure you correct it fully on the ClinCheck. And can the aligner have a push surface on an attachment that's not going to actually intrude that canine? So if this canine were rotating, this tooth might actually intrude, and it won't be, there's no push surface there. That's really an extrusion attachment. It's not a rotation, but it tends to be more, if it was, let me see if I can go back. A root control attachment will generally be triggered. So there you go. There's my canine control attachments right there. Yeah, I've gone past it. Stop right here. Now this stop. He doesn't want to stop. Okay. Now this is small. So this is really just going to hold my canine in. If I need to rotate a lot, it's going to be a longer one, right? More like this. So this premolar is rotating and also extruding. So I need to have a really useful rotation attachment. So my tips are: final position, make sure you correct that rotation in your final position, and have a good attachment that the aligner will grab, and put that attachment on the lower occlusal third so that there's no way the aligner can't grip that. And then the canine has to fit into that attachment.
Thank you for your answer.
Sure.
The next 2 questions is about extraction. The first one is, do you use lingual attachment for space closure in extraction case? And the second one is, do you use staging for closure of extraction case? If not that staging, how do you prefer to close extraction space?
Okay, so I told you this is the case, the dentist's son. Let's let me do this for a second. I wonder if I can do this. Can you just repeat the question? So I know it's about extraction, so I'm just pulling up.
Yes. The first one is, do you use lingual attachments for spaced closures in extraction case?
No, I don't. So, oh, sorry, I do, but on the anterior, not for the extraction space closure. So let's go back and look at the one that I proved and see how I close the space. So my palatal attachments are generally just anteriorly. And then I showed you some for the mandibular torque. So this is where he started. So this is the one I proved. This is G8 on top, because I'm not, if I was extruding or really rotating this canine, like the previous question, then I'm going to change this attachment. But all I'm doing is retracting it, so that optimized attachment trigger is going to be fine. So this is what I did. For me, the trick for extraction spaces is staging. It's not so much, you know, what amazing attachments, buccal, lingual. So if we go to the upper, yes, I have some palatal attachments, but I explained that before. Instead of a power ridge, I'm going to have this attachment. It's going to be more aesthetic. This attachment for me helps me extrude, rotate, retract, and torque. So I love them, and it's aesthetic. The downside of this is if you don't have a big overjet, the patient can bite on it and then it's uncomfortable. So you have to, I warn my patients, do you want something, I call them the V attachments, right? Vanity or vascular attachments, vanity. Do you want to be vain and have them on the inside? Or do you want possibly, you know, and a bit of discomfort, or I can put them on the outside. But coming back to extraction space closure, for me, it's staging. I really think about the staging and the effects of that. So at the initial here, my 3 and my 5 are closing. There is no negative effect. All I'm thinking about here is root ahead of crown. So I'm just going to slightly have a bit of distal root tip on the canine, a bit of mesial root tip on the premolar. Nothing dangerous here. So now my molar is coming forward, and now my arch length, or my first molar is coming forward, my incisors are retracting. So now I can be at the risk of loss of torque, which can result in incisor interference. And my posterior molar might start to tip. So I have to be very careful that I don't lose my torque, and I'm just not flattening my incisors, but bringing them back almost bodily with a simultaneous palatal movement. So I can control that. Canines coming back, all I'm doing is root ahead of crown. So I can control that. No big side effect there. And then maintain my torque for my incisors. So it's more the staging. I don't just go molars forward, incisors closed, because to me, that's how we end up with a lot of bowing effect and a lot of posterior tipping. And once you've got molar tipping, very difficult to correct it. The only way I can correct molar tipping is to push it back again and then bring it forward with all of the techniques that we talk about today, overcorrecting the root and a nice attachment. So this is G6. This was a pure extraction case with G6. The only thing that I did different was the staging, and here on the lower, this is again TAS, the dentist's son, where I leveled, and you'll see how he came back. And what I'm working on now, so this is now his refinement. I mean, this is how he finished, and that's not bad for an extraction case. If I was lazy, I would say, okay, go away, you're done. But now I can make it look even better, and this is the finishing, and that's exactly what we should be finishing today, not anything difficult like, you know, a train wreck. So we already worked on this together, talking the molars, extruding the 5. And that's what I had in my modification. I made this movie just this morning before I spoke to you. We placed those on here, on the palatal for the talk, so I can get some nice buccal root talk. So they're the only lingual attachments that I'll place.
Thank you for the sharing of your space closure staging. We have another question. Would you still place palatal attachments on posterior teeth for buccal root talk even with the introductions of GA?
You know, no, I won't, because I like to test what they give me, right? If I mess up, you know, these systems, and I love John Morton. I hope you've all had a chance to listen to him. I think he's very clever. He understands orthodontics because he was in orthodontics way before Invisalign, and he's an engineer. He's just really, really clever. So if we, and you know, he's one of the team that's working on all these things. And if you think about the future of where digital appliances are going, they can only get better. And I've kind of already mentioned that, because we're learning at such a more efficient rate, and all of this is documented, and we can just modify our software and build and build and build. We're not relying on all of this manual stuff to learn and to change and then to teach. So if I don't test what they're giving us and their products, I'm not going to know if it really works. The other thing is, if I do half and half, then I also can mess up what they give me. So things like G8, things like G5 and G6, I like to use purely. And then if I see what I like, I hear what others are saying, and from there, I will make my protocol. So the answer is no, I won't do this on my 6, possibly my 7, because G8 is not for 7s. It's only premolars and molars, possibly still my 7. But what I have to do is go back to John Morton and say, hey, John, if I do this, put my lingual attachment on the 7, and I'm mucking up what you're staging on my 6, because that's something that is also possible, that, you know, teeth that are moving next to other teeth also have an influence. It's one unit. It's a little bit more separate than fixed appliances when we bend a bracket and another tooth goes up or reacts. But we know from our studies that if you do something with an aligner on one tooth, the next tooth is going to react a little bit, not as much, but a little bit. So the answer is no. I try and use their things in the purest forms that I can.
Thank you. Another question, Doctor has 2 questions actually. When do we program palatal or lingual attachment is his first question. And the second one is that if we do not want intrusions of the incisors, for example, due to the semi-line or low angle skeletal to patients, do we still program anterior Byrams?
Good question. So I'll do the second one first. You know, I'm very protective of the smile line, because you have to realize, we all realize, right, that that's really what the patients want. We want everything great. They want, at the very priority, a good smile line. So I'm always so careful about intruding upper incisors, and, you know, very rarely will I intrude them. You know, I use the gingival margin to see if they're super erupted. So if I go back to, you know, this young boy's case and treatment plan 6, the one that I approved, when I decide to intrude teeth on the lower, look at the gingival margin. No, that's not one, this one here. So I can see what I need to intrude here. I follow the gingival margin, and I know I need to intrude the canine and the incisors. That's an easy one. When it comes to the upper, get rid of the IPR. I know here it's telling me that I actually also want to intrude. Then I'm going to look at the smile line. I'm sure actually I'm not going to, these photos are terrible. You know why? His dad's a dentist, and his dad's took the photo for me. And these are not my photos, but anyway. So I don't want to intrude the upper here. I'm going to intrude, look at the gum line. This will show you what you want to intrude. And hopefully I did that. And make it level. Well, here actually it's showing that the upper's coming back. Let's look at the super. And the upper's extruding a bit, which is what we expect when we retract, which will give him a nice smile line. So yeah, being really, really careful of what we intrude. Now, am I going to use, so the smile line, to tell you, use gingival margin and the smile line. Are we even going to intrude them? Will I use bite blocks if I don't want to intrude upper incisors? If I need them. So if I've got a crossbite, posterior crossbite, I think it helps me, even though the aligners aren't in all the time. Yes, I will, but not routinely. So they're going to be triggered on the treatment form really easily, even if there's 0.5 mil of intrusion. And sometimes when we're extruding, we know that the bite's going to get deeper, right? These incisors, because of the bowing effect, relative extrusion, the overbite actually naturally, because of loss of torque, that overbite will get deeper. So putting all that together, the original smile line, what the mechanics are doing on the upper arch, if anything, I'm already going to be a bit deeper, then that will tell me whether I want to use bite blocks or not. I don't think you need to be afraid, because bite blocks, as I said, they're not the whole solution. So if you have a bite block or don't have a bite block, I don't think clinically you're going to see by itself a lot of difference just because of the bite block. It will be what you've actually programmed. The bite block will work in your favor in maintaining or maybe intruding by 1/3 of a mil from the studies that I've seen. It's not going to make a lot of clinical difference. So don't worry about your smile line with those, the bite ramps. And the other question was, sorry, part of that.
When do you use lingual and when do you palatal attachment?
So I kind of, answered that. Anteriorly, palatal, because it's aesthetic. And I started doing that with my adult patients. This is a teen patient, and I still do it because they're great mechanically. It helps to work really well. If it's a tongue thrusting patient, a young patient, they can help me with the tongue as well. The only trouble with these is when you're coming to an end, if you don't have overjet and maybe you want to absolutely extrude, then it's going to interfere. Then you have to be checking. But at that point, you can actually take them off if it's retracting. If you're absolutely extruding and you've got no overjet, that's going to stop you. So if you start with no overjet, then, and you need to extrude those teeth, then it's going to go on the labial. You need overjet to place them. So that's anteriorly. Posteriorly, when do I use palatal attachments? Very rarely. And it looks like from today that I do it a lot, but really because we were talking about expansion and buccal root torque, that's when I will help my buccal root torque. And it's not when they're expanding. From now on, if it's a new case, I'm either going to have G8 or I'm going to have just a little buccal attachment, because it's better to go simultaneous just with one buccal attachment. Simultaneous buccal root torque, expand, and one attachment here. You don't need a palatal attachment if you're initially expanding. The reason they had it on the ones you've seen is because now I have to create a big moment, because I got the transfer case, it was expanded, I have to get out of this. Now to get the moment, now I'm using the palatal attachment, but not when I'm initially expanding. So very, very rarely. Even if I have, I'll see clean checks from doctors and they'll have an in-standing, this one's not the crossbar, in-standing premolar. It doesn't make sense to have it here, because if you have a lingually positioned tooth, where is the aligner pushing? It's pushing on the palatal. It's already got a push surface. Then then I would just put an attachment here to make sure the tooth doesn't intrude. And you've got much more room to put an attachment here than when you've got a lingually positioned tooth. So very rare will I use the palatal attachment. Anterior aesthetics, or if I really now need to correct a lot of buccal root talk.
Yeah, thank you for a very nice answer. We have another question. Could you please talk about another gap problem, the gaps between teeth lose posterior contacts, even when the teeth are not moved in clean check? The cause, prevention, and solution. Can you share about that? Thank you very much.
Okay. Yeah, that's a good question. You know, I want to say that it doesn't happen to me a lot, but it does happen. And when it happens, if it's in the final set, the refinement set, that's really annoying. So what I want to do is if I'm going to get, if I think I'm going to get, or I think I have a gap, sorry, I thought I took out the phone, a gap in my molar space, then I want to build in my IPR in my additional aligner, and I want to find it in my additional aligner. So why does it happen? Look at the, you know, the possible causes. What would possibly create a space here between molars? If we're expanding with aligners, usually we don't express as much expansion. So you'd think then we're going to finish with actually a tighter contact and not a looser contact. It can be insufficient rotation. So look at the molars, see what they're doing. If this molar perhaps doesn't rotate fully, and molar rotation is actually not, it's I don't like the word predictable, but it's highly expressed movement. People think it's difficult, but usually it's a square tooth and there's a lot of surface there. So my answer to why we would get a space would be lack of full expression of the program movements. And I don't know if I can actually identify a very clear one cause why that's happening. Obviously, if we had space there in the first place. Obviously, if we do too much IPR, they're the obvious reasons. But I think that the doctor is thinking much more subtly. Sometimes it happens and we actually haven't done movement, and that was actually in the question. So how can that possibly happen? Possibly then if the patient's biting on the aligner and we got some intrusion, but you know, I don't fully think that that's going to happen in every case. But assuming we've got the space, the next really important thing to do is to make sure we identify it, because what you don't want to do is ignore it in a refinement. What you don't want to do is be finished, go, yes, I'm done. It was a really, you know, high five. We're not allowed to do that anymore. Really hard case. Extraction space is closed beautifully. Patient comes in, they're wearing the retainers, gorgeous smile. They sit down, how's everything going? Take out the Vivera and they say, everything's great. You know, patient, love my smile. People say it's great. I'm getting some food caught. And you take your little strip, which is on my tray, and you go down and it's a loose contact between the molars. And now you think, great, I've finished my case. What do I do? So that's what we don't, that's the worst scenario, right? Because now what are you going to do? Order Invisalign, you know, light, or order additional aligners, try and put some dimples. That's a possibility if you've had a bit of intrusion. You know, I said you have 3 Vivera, so that's great. You can use 1 Vivera and put some dimples interproximally, and that will extrude slightly. Or if you put a dimple posteriorly, but be careful to do it under the contact point, not over, because if you do it over, you'll intrude the tooth rather than extrude. So you can do everything very simply from dimple pliers. And adjunct, I would only use a sectional if I had a lot of space to close, or, you know, something else I was trying to do. I don't use sectionals very often under Vivera. So in that case, avoidance is again the key. when I sit down for my refinement, and I did it yesterday in the clinic and the day before, my assistant's sitting there and I look at everything, what I want to do, and I ask the patient, if there's anything that you would do to your teeth, what would you do? You have to be careful because sometimes they're very picky, but most patients will be able to answer that reasonably. And at that point, you ask them, do you get any food caught anywhere? Because you want to identify those loose contacts. Then in my additional aligners, you'll program that 0.2 in that contact point, and then that will be taken care of in the refinement. So for me, because I believe in physics, right? This will never do 100% of what it's programmed to do. It's nothing to do with the company. The company does the best job, has the best aligner on the market. It's to do with physics and engineering, and also me. I'm a patient, I'm alive, I have different routes to what the treat program does, and I always will have. Some patients will wear it 20 hours, some patients will wear it 18. So no matter how good Align technology is, it's never going to be 100% in this for every patient in one series of aligners. So what's my answer to that? Additional aligner refinement. But I have to make that short and smart, and I have to build that treatment time into the original. So if I have a loose contact, I want to identify it at that refinement time so that I can just build in 0.2, 0.2, but not do it clinically. And that's how I would take care of that.
Thank you. Another question is that, can we use Byram on the anterior teeth for raising the bite to correct crossbar in the posterior teeth?
Yeah, so that's yes and no. Your mind tells you, because I guess if you use fixed appliances, we have bite turbos, and they will always have the bite open even when the patient's eating. With Invisalign, it's a bit different, right? Because the patient actually takes out, I'm not sure where my crossbite one, I think I have one somewhere. The patient will take out their aligners to eat, and that's when we lose the bite ramp. Now, one way of doing it, if you want the permanent bite ramp, is do what, the anterior attachments. That's always a permanent bite ramp. If you want to make that a permanent interference, you can. I know where it is. It's in staging. It's here. So while the bite ramp will help in a crossbite when the aligners are in, it's not going to have any effect when the aligners are out. But still, I think this tooth, I want to help it and disocclude the aligners even when their aligners are in. So if this comes to the occlusal view, you'll probably see, yes, I have bite ramps here. So it seems like a lot of you are worried about bite ramps. Don't be worried about, yeah, they're on the canine there, I could see them. Don't be worried about bite ramps, because there is very little negative effect from a bite ramp, but you can only gain from a positive effect. I think the only problem a bite ramp might cause is if you give it to a patient in additional aligner when they didn't have it in the first series, because then it feels different. The aligners feel different. It's like having a power ridge in additional aligner and on top, and you didn't have one in the initial series. I'm pretty careful about things like that, because patients will know, it only takes them a day to get used to, but they'll notice the difference. So if I'm a question, should I put one or shouldn't I? Put one, because it can only help you. It can't hurt you.
Okay, thank you for your answer. To be honest, we have a lot of questions. I'm not surprised, because the lecture is very interesting, but I think that we can only have time for one more questions. And then maybe we can reserve the other question to another lectures. We have a lot of questions about extraction too, so you may have to do another extraction lecture with us. Okay, so last question is from doctors. How do we know that an optimal attachment given is not enough?
Think about what you're doing, right? Think about pushing. or, you know, aligners push. Okay, so I'm not sure if I've taken away all my, yeah, I mean, this is the key to attachments, right? Enough is that what happens, where is the push surface? And for optimized attachments, it's very easy to see that. It's the only flat surface on the optimized attachment. So if you look at the root control ones, there's two little push surfaces. You know it's going to move the tooth, the moment of force. If it's extrusion attachment, the push surface is on the top. It's like a little ski ramp. If it's a rotation, the push surface is on the side and you rotate or rotate and extrude. So imagine that. And then think about the other movements. You know, there must have been a trigger for that to be there. And then think about the other movements that's happening. Is it also going to be okay for extrusion if it's just a rotation attachment? Or if it's a root tip attachment, is it going to be okay for rotation? No, it's not. Is it going to be all right for extrusion? No, it's not. So you need a ledge. Extrude, rotate. Think about pushing, and then that will tell you what kind of attachment design will be sufficient. The other thing is where to put an attachment. Now, if you've decided, okay, I think my optimized attachment will be good for root control, but not for extrusion, so maybe I'm going to make my own. Now, where do I put that attachment on the tooth? Think about the ice cream cone. When it's the aligner is going onto the tooth, it's more flexible here. So the higher the attachment, the less grip it's going to have. So if I'm extruding a tooth, I want my attachment down here near the occlusal or the incisal edge. So yeah, just think about where you're going to push, what movements have to happen, and that will, the design will come to you.
Hi, Dr. Vicky. Thank you. Thank you for addressing all the questions, and thank you for your great presentation. Very interesting, very nice finishing. So once again, I'd like to thank all our doctors for attending, and also Dr. Vicky for this day. And let me just, yes, I like your slides.
We're at the station.
Yes. Let me just share my slide for some of our reminders.
Thanks all the doctors for attending, and thank you, Align Technology.
Thank you. Thank you very much.
And for giving me the opportunity to see you. I feel like I'm talking to someone. Thank you.
Thank you very much, Dr. Vicky. So I would just like to remind everyone of our upcoming Align APAC Virtual Symposium. Please block your calendars on the 20th